Well, hello from Australia, and thank you to the FIP for the opportunity to present these findings from our study over the last year. And the authors of this project have nothing to declare. Early in September, this annual overdose report was published by an Australian research institute whose role it is to provide evidence of and inform drug-related strategies and education. The report for 2018 showed that the largest number of deaths attributable to drugs involved opioids, and that 900 of these were unintentional. And pharmaceutical opioids, excluding methadone, were responsible for over half of the unintended overdoses. And it was in the middle of 2018 that the Australian Chief Medical Officer of the federal government sent communication to those GPs whose prescribing of opioids was in the top 20th percentile across Australia, regardless of their field of practice. Many GPs were quite affronted by this action, but for others it became an impetus to reassess their prescribing habits. Last year, a local general practice was successful in achieving some funding to employ a practice-based and non-dispensing pharmacist. So this is a developing area of professional practice for pharmacists in Australia, and it isn't yet federally funded, unlike some of the other non-medical specialties such as dietetics and psychology. So I was very excited to be able to take on this challenge. So the focus of the project was on high-risk medicines and people at high risk of medication-related adverse events, as well as high-risk medicines prescribed at transitions of care, as these are points well recognised as being associated with harm in the patient's pathway. And is one focus of the World Health Organisation's global challenge to reduce medication-related harm. A major part of the project was to focus on opioids, and this was because of the known harm from opioids, but also that drive for the GPs to review their prescribing, and also the long-term persistence that's well known of opioids for a proportion of patients after transitioning from surgical procedures or acute care or acute injuries. So for the aim of this part of the project, which I'm presenting today, was to assess the impact of the new position of the practice pharmacist on the management of opioids, including for those people transitioning through care, and also to describe the factors that contributed to opioid reduction. My first activity was to formulate an opioid prescribing policy, or an opioid practice policy. It was developed iteratively and accompanied by education for the practice and endorsed by the GPs. Some of the components of the policy included the regulatory or legislative requirements, information on best practice for the review of starting and continuing patients on opioids, a recommendation to review all patients prescribed opioids, particularly those patients with chronic non-cancer pain. It also included some practice policies on harm minimisation. And so these were things such as our opioid agreements, which were developed for patient engagement, supply of naloxone, and recommending a second GP as a prescriber for each patient prescribed long-term opioids. So for the review of the patient's prescribed opioids, first of all, the patients were referred to me as the pharmacist for medication reconciliation to start that conversation about opioids, the limited benefits in the face of harm, and also to discuss the opioid agreements, which was a new concept for a lot of these patients. The patients were also referred to a second general practitioner for review, but also there as a prescriber if required. Opioid resources were used or developed if they weren't available or if we didn't think they were appropriate. So through our conversations with the patients, we use the opioid risk tool if this is applicable, but it's not applicable to all patients. And also personalised handouts about harm from opioids. These were populated from the software, which once again outlined the potential harm of opioids, and a discussion of our opioids agreement or contract, and in that there was a focus on achieving functional goals, just not pain relief, for the ongoing use of opioids. I also developed a template which could be populated from the prescribing software for tapering plans if it was agreed to and if they were appropriate for the patient. The Australian and New Zealand Faculty of Pain Management has an app which is used by many clinicians on a phone or computer to standardise a dose of opioids to oral morphine equivalents, or OMEDs, or daily OMEs. And it also uses this traffic light system shown here, which shows the target ranges to reduce the risk of harm. And there are many such tools available, but this one is local and it's used by many specialists. It's also very easy to use and became a good device in education of both the GPs and the patients, and I used it for data collection. So the data were collected from September 2019, when the policy was first implemented, until May 2020, and included the patients' demographics, their opioid use standardised to the oral morphine equivalents using the app as shown here. And these were calculated at baseline and at 6 month and 9 month reviews. The cohort data were collated and also the strategies used to assist in patient engagement and tapering were noted, as well as just general pharmacist medication review details, which we'll be familiar with. So to go to the results, 100 of the 111 patients referred for a pharmacist consultation were reviewed. Some had up to 7 consultations. And 18 of these patients had been prescribed opioids at discharge from the hospital. At the 6 month review, it was 98 patients. At the 9 month, we had 92 patients in the patient cohort remaining. The average age was 67 years. The 63% were female, and patients had been taking these long-term opioids for up to 20 years, but the range, or the mean was 8 years. So as a project objective was to increase the safety of the opioids. Minimising the dose can reduce the risk of harm, and the cohort daily oral morphine equivalent was compared at baseline 6 months and 9 months. The median daily OME was reduced significantly by 6 months and remained so at 9 months. And the mean, median and interquartile range were all reduced to a safer range according to the Faculty of Pain Medicine, and it's depicted here in green. The overall change to daily oral morphine equivalents was determined. And at the end of the project, there was still 18% of patients who had no change to their daily OME, but 39% of patients no longer had prescribed regular opioids. For the cohort, there was a mean reduction in the daily dose with a range of 0 to 100%, but the mean was 68%. So what helped make these changes possible? Besides having an embedded and practice-wide attitude, which was really important, having a patient-centred approach which acknowledged the patient's concerns and listening to their preferences. For example, for weaning regimes, like the rate of weaning, the timing of unequal or split doses when that would suit the patient across the day, being able to apply expert pharmaceutical knowledge about the kinetics and available formulations to weaning plans. Communication with all of the patient's other care providers was important and used, and developing personalised tapering plans for which were saved in the patient's records for review if required. And so to finish, this project has contributed to the safe use of opioids for the patient and the practice and the GPs, and it's demonstrated interdisciplinary clinical governance. A coordinated intervention was implemented, all were committed to the strategy, and patients were engaged, and patient engagement was essential. Most of the patients were engaged. In summary, stewardship principles have been demonstrated, and these are transferable to other high-risk medicines, potentially. So we would like to acknowledge the funding, acknowledge our source of funding from our local primary health network, or WNER, and also the patients and staff of WNER Medical Practice. So thank you very much for listening out there.